So our next speaker is a diplomat of the American Board of Oral and Maxillofacial Radiology and the American Board of Oral Medicine. He's been chair of the Department of Oral Health Science at the University of Kentucky. He was the first associate dean of clinical affairs at the Arizona School of Dentistry and Oral Health, and was a graduate program director of Diagnostic Sciences at Indiana University. He has authored over 135 scientific articles and 6 textbooks on radiology, including the best-selling book, Atlas of Cone Beam Imaging for Dental Applications. He currently practices dentistry full-time and is an adjunct professor of oral and maxillofacial radiology at the University of Texas, San Antonio. Please give a welcome to Dr. Dale Miles. Thank you.
And I want to just let you know that I was a dentist up till 1999. I did one day of general dentistry at all the schools I taught at, and there's more than on that list. And I graduated in 1974, so when I gave up the handpiece, what's that? When I gave up the handpiece, I was doing it one day a week in faculty practice, but I actually practiced for about 7 years outside of Toronto, got bored, and went to San Antonio to do my graduate work. An adjunct professor, by the way, equals unpaid, okay? So just to let you know, it's just a way of keeping an academic credential. So you were at the picograms per milliliter level. I'm going to take you back up, okay? We're going to take you back up to the level of the clinical dentistry. I think most of this will be fairly routine for you. If you want to understand the osteolysis that occurs with NICO, you got to understand this, and you got to recognize that molecule. Does anyone know what that molecule is beside Dr. Lechner? Well, that's the Rantes molecule, 3-dimensional. I'm an image guy. I'm a radiologist, right? All right. So the only thing I can't do is I cannot take you through the basic principles of CBCT. If anybody was thinking they were going to hear that in the first part of the talk, good luck. Okay, I do a 2.5-day program. I do a 1.5-day program at Gordon Christensen's and a 2.5-day one in Toronto every year, and I barely get through the content. So if you want to look at my lecture schedule I've got a website, drconebeam.com, Dr. is all spelled out. You'll see my schedule. But I am going to show you some of the images in the back part of the talk of things we can do with cone beam. The unfortunate part is for everybody that wants to, find them on the images that you take in your office, again, good luck, okay? I think Dr. Lechner showed some beautiful intraoral and what they call OPGs, or panoramic type images. I don't know why that's doing that. It's maybe too close to my mouth. That might be better. Is it me? I don't know. Is it me? I feel like one of those wind guys, All right, he showed some interesting images, and I have some questions for him, but Hounsfield units do not relate to intraoral or panoramic. They actually CT values from -1,000 to +1,000, +1,000 being bone. And maybe there's a correlation in the software that Cavo or whoever sold him the machine made.
Hold on, we're going to change the mic.
Good, okay, because that's driving me nuts. I'm sure it's driving you nuts too. Anyway, what I'm going to do in the back half is show you some images that basically are comparable to what you're getting in your offices, okay? I'm going to stick to cone beam. Some of you are adopting, some of you already own cone beam. Some of you, unfortunately, have machines that give you crappy images, okay? And I have to say it like that. I have no connection to any of the companies at this point in time. But I am going to show you some of the tools that are available in software products, one in particular that I use, okay? And the only disclaimer I have is I don't pay anything for it. I do beta testing for the company, so they let me have it to run my practice. So I guess that's my financial disclaimer. I have no miracles, okay? I am retired. He said, why would you want to hire me? Because I might kill whoever it is you want me to miracle. He's already dead. He is, eh? I'll take a look, That's a safe consult, okay? First, do no harm, remember? All right. So, by your definition of this organization, 2015, chronic ischemic bone disease, and you may have updated or changed it, this is the one I could find, is basically bone death. Creates diseased or dead marrow, resulting in a diminished abrupt or chronic, acute or chronic blood flow. So, and then we heard Dr. Lechner's lecture, who basically said, here, based on these measurements that I can make with the various devices, I actually can go in and take some tissue in the rantes. And it was a very impressive sort of inflammatory mediator. It attracts cells to the area, okay, to fight inflammation. So I was impressed with that. I still do have some questions. Unfortunately, I got to scoot right after here because I am going up to Toronto and I have to go home and repack. And I've always thought of it as an infarct, okay? Now, it may remain an infarct, but it may be populated by stuff. So what I did was, over the years, looking at this, we've come to the understanding that basically an infarct leads to osteonecrosis. That's a widely accepted term. It could be of vertebral bodies. It could be jawbone osteonecrosis, like in BRONJ, from a specific, sort of drug. But at least a focal infarct in bone is a definition for osteonecrosis. And this comes right out of a very good journal, okay, and people that are studying this all the time. And we know about that. You saw the rantes in rheumatoid arthritis, so we've known about this in radiology for a long time in medicine. Okay, I think maybe we can make some parallels there. So osteoporosis is not a specific disease, but it's an entity. It's a marshalling of things that are either going to heal or, cause some problems. What I couldn't figure out is if you've got necrotic bone and there's recruitment of cells, where's the pain come from? Because some are painful, some are not. I think that sometimes at the margins with the capillary proliferation, there must be some neural elements with it that then cause this chronic kind of painful problem. And this is one of the best papers I could find. You have this citation in the presentation that I gave you as a PDF, so you might want to read this. I found it very, very good. But the infarct, an interruption in the blood supply can result from things such as thrombi, infection, diabetes, kidney disease, hemophilia, increased steroid levels, immunosuppressant therapy, okay, bone trauma. We're all concentrating on bone trauma, but as you recall, there's a patient on the end of that tooth, okay, and so you are the dentists that are looking at the biology, the chemistry, the immunology of what's happening at those levels. However, radiologic tests will not necessarily reveal a bone infarct. And this is where I'm coming from. I may be at odds with Dr. Lechner in some areas, but I don't go in and treat them. I have the luxury of just being the guy that looks for occult pathology in your scans and then makes you refer somebody when there's an appropriate finding that needs referral. So I went through, and I've been doing, it's like going down a rabbit hole, guys. I'm sorry, I appreciate what you're doing. I would not go there at this stage of my career. I'd much rather look at the images and help you determine whether or not you should treat. The paradigm for dentistry, unfortunately, is that most of you, despite the biologic bent, you're still surgeons, okay? I had a case the other day sent to me by a California dentist. Well, actually, it wasn't the dentist, it was the patient. She had imaging done at a mobile imaging service. She wanted another person's opinion because the biologic dentist, and he may be even in this room, I don't know, the biologic dentist took a panoramic and said he saw 4 cavitations. And I'm going, God dang, I want his pair of eyes because I'm not sure I see cavitations. And I look at this stuff all the time. Now I'm going to show you some other interesting ways of maybe getting to the truth, from an imaging point of view, but that'll come towards the end. So I kept thinking of it as an infarct. And then from this same paper, okay, this definition of bone necrosis by a pathologist, he says the same things that you're seeing, and I'm sure Jerry sees in his, histology specimens, is that there's a proliferation of capillaries, fibroblasts, foamy histiocytes, and then there's this breakdown of the marrow. And some of you have been in those cavities, so you know better than I. So here's my simple approach. I think it all starts with some injury. It could be biomechanical, it could be chemical, it could be some type of immunologic insult, but it's an infarct, okay? So there's a loss of bone supply because there's no, vessels to that area. Maybe some things being recruited at the periphery. There's a paucity of cells to clean it up. You've got giant cells, macrophages, whatever, and some of these lesions end up under the microscope of the histologist or the histopathologist who gives it a label. And then we have a, quote, diagnosis. Cavitation to me is not a diagnosis. It's something you guys see in an image or measure by transducing, okay, mechanisms. So sometimes there's a lack of inflammatory response, and I'll show you where I think that ends up. Sometimes the inflammation is at the margins where the neurovascular elements, and it can be painful or not. Now this person, this woman, I get phoned up by the tech, I want to read on my scan because he ordered it. He saw 1 on the panoramic. When he ordered the scan, he said he saw 4, and I don't have any symptoms. I'm totally pain-free. I had, and I'll show you her image in a minute, she had a little bit of calculus and some periodontal inflammatory change at her gingiva. She had no other signs or symptoms, okay? So here's what I did, and this is back in about 1991. I was thinking about the potential pathway of what histology changes would give me this radiographic appearance. This is a great book, no longer available because the damn Library of Congress marked that book. Look at the title of it. They gave it an ISBN number to put it in the path section. So that some people go to the radiology section, they could not find this book. And it was like, hello, it's called Oral and Maxillofacial Radiology. Radiologic pathologic correlations, okay? I'm going to resurrect it because Quintessence is interested in it. But in any event, here's what I did. Trauma or vascular insult results in some intramedullary hemorrhage and an infarct. If the blood supply is maintained, they could even connect and they form what we would call an AV malformation. You don't want to cut into that, you know, because the patient will have a bleed to death possibly. If the blood supply is only partially maintained and there's a giant cell reaction, you could get an aneurysmal bone cyst. You could get a blood-filled sponge, but they're not totally connected, but the cells are in there trying to clean it up. Or you could have the blood supply partially maintained, a significant giant cell reaction. Duh, what do you get? You get a, you know, central giant cell granuloma. These all look like multilocular lesions. Traumatic bone cyst, the very end one, can look like a multilocular lesion. But its blood supply is cut off. There's no reaction, so you get a big empty space with some scant fibrous connective tissue, a little bit of heme sometimes, or straw-colored fluid, right? So, okay, that was 1991. I went out and found examples of them. So here's the same thing I just read out to you. I won't go over it, but here's the AV malformation. There's some blood-filled areas in an aneurysmal bone cyst, and there are some giant cells around it. Here's a central giant cell granuloma with maybe some vessels in the rest of the specimen, and here's a traumatic bone cyst. And it's got nothing. Cholesterol clefts in there, a little capsule, you know, around the edge. So that's kind of what the histology looks like. AV, ABC, central giant cell traumatic bone cyst. Along comes this guy. Here is some bone, fibrous connective tissue in here, and a little bit of fat. This is an infarct. Okay, this is the tissue that might get broken down that produces all those chemical agents and other cytokines and chemokines, as they call them sometimes, in the bone. So that could be maybe the pathway to one of the lesions that you're all about, okay, the cavitational osteolysis. So there's the fat. It's there. So what I said was, well, maybe I need to update it in the new book. I have to do a little research. I started down, like I said, that rabbit hole. I don't know where you end reading about these particular pathways. I spent 6 months in the PATH service in San Antonio when I was a resident in 1980-81, and I never got beyond inflammation. They never took me on the scope into any odontogenic things because they wanted us to understand. We weren't in the PATH program, we were in a diagnostic science program. So what I said was, maybe if the blood supply gets cut off, there's no giant cell reaction and there's necrosis, maybe that's the next thing in the chain. So I showed this to Charles, verbalized this to Charles Rufinacht. Is Charles here in the audience? I didn't see him. He didn't come up and say hi. He's a dentist out in California, not the guy I was talking about earlier. But that's very interesting. We should get you to come and talk about that. I said, well, they don't want to look at histology necessarily. I'm a radiologist. So now we'll get on to the other stuff, all right? Now, over the years, you know, after Ratner first reported it, or if you go all the way to G.V. Black, sure, okay, but plain radiography wasn't sensitive for detecting it in bone, despite what you saw, you know, on Dr. Lechner's slides, which I thought were very impressive, and I was impressed with the lecture as well. Radionuclide imaging was the next thing to come along, but it was so sensitive that after, most people did it after they dug around for a bit and tried to cure the patient, and then they sent them for a scan. Well, of course it's going to be hot. They stirred up all that inflammation again, okay? So maybe MRI, and there's some literature out there. Now here's the lady, okay? If you look at this, you'll see a panoramic image with nothing going on. She's got her full complement of teeth. She's got a small mucus retention cyst in the right antral space. She's got, if you look carefully, some of you up front will see the calculus, but she had no complaints, okay? So what can we do? Well, we can actually do thin slice pseudopanoramic. When you have software, and some software doesn't allow you to do this. If anybody wants the name of the one I use, again, I don't have any commitment to it except other than I beta test for them. It's called On-Demand 3D, and it's powerful. I'm going to show you I can actually use a virtual endoscope and go in the mental foramen and down the frickin' canal and see an implant in the canal. I've done that in 2 or 3 court cases. So, but I want you to look at this. This still looks like a kind of a panoramic, and none of these teeth they're not missing. This is at 1/10 of a millimeter. Well, why wouldn't we use an image like this to look for those small, quote, cavitational areas, okay? And if you look at this, somebody might go in there. Somebody might look here and go, oh, maybe I'll go in. But I don't want to be the patient where the guy says, I found 4 cavitations and we got to go in. You know, dentists are surgeons. You're surgeons. I hate to tell you that, but I'm in the cognitive side. You know, I did diagnosis and radiology for a reason. I got bored doing dentistry. I'm sorry. It was fun while it lasted, but I wasn't challenging the brain. That's why you guys are in these kind of lectures. You're challenging yourself. And when you put a crosshair on the area that you think it might be, and it comes up in other sort of appearances, you can maybe get a little better information from it. Now, these are not even true Hounsfield units, even though we call cone beam CT. It's not even CT. I'll give you one principle. We get cubes of data in a cone beam scan. We don't get pixel data until we display it. We get voxel data. We get little tiny cubes, about 1/10 of a millimeter in size. A true conventional CT scan gets every point of every piece of tissue in the patient's body in the scan. That's why the dose is so high. That's why you got a gantry going around you. What do we do with cone beam? Oh, look, we got CT. No, you don't. You have volumetric tomography. It bears no resemblance to the way you get it, the dose, any of that. The only thing that looks CT-like is what you get in the software at the end, because you can do funny things to it, fancy things to it. It's called feature extraction. And feature extraction is to let you know that you can make a better diagnosis. All right? So you can change these things around and make it nice. Enter cone beam CT. That's going to solve all our problems. You got to understand it first, and it won't be in this 1-hour lecture, I can tell you that. I get people at the end of 2.5 days in Ontario, Canada that still can't pass the exam, which means they can't get a certificate from the Royal College to be able to buy a machine. That's what happens in Ontario, Canada. You want healthcare like Canada? Bring it on, okay? That's why I left the country. We won't go there. You don't want healthcare like Canada. My father-in-law had a rotator cuff injury 8 months before he got it imaged by MR. First, he had to see his primary care provider. That took 2 or 3. Then he had to see a specialist to confirm with the primary care provider. That took another 2 or 3. And then they had to get into the scanner, of which there were only like 6 in Ontario. There was not one on every corner, you know, like there is in Philadelphia or Boston. Anyway, here you go. So it's just another imaging modality. It has very, very high spatial resolution, high detail. And some vendors will say, yeah, smaller the voxel size, the better the detail. No, more detail in it, but more noise. I mean, there's trade-offs all over the place, and if you don't understand it, you're going to buy the wrong machine. Lots of you have bought the wrong machine. CBCT has many, many errors and artifacts. And by the way, minor movement in a CBCT scan will disrupt some of the information that you get. So you have to have something that fixes the patient's head very stationary. And most dentists don't understand any of this. Okay, that's the biggest problem. You can read a book, you can buy a scanner, you can have the tech come in or the sales rep, and they'll show you how to position a patient, get a beautiful image, and then they go away. And then you go, these images are great. What the hell am I looking at? No, seriously, that is the first reaction. So there's a huge educational process that goes on with adopting this technology. There are no miracles, okay? So I'm going to do a demo. And the demo is going to be to show you something unique. This is the interface that I do. I thought I'd change this up a little bit. And I have a case open. I've shown it several times before. And this is the DICOM data. I'm going to open it in one of the toolboxes called Dynamic Light Box. So what you're going to see is you're going to see, first of all, axial slice data that I scroll through. My right click, I can window and level. I can make brightness and contrast. I mean, you get used to this. Everything happens on the mouse. You don't have to pick up a tool all the time. It's just fantastic. I can filter it, put on a sharpening filter. It looks a little clearer. Make it a little clearer even still for you. See how the detail came out there? And now I'm just doing a little bit so you can all see it, okay? Now, tell me when you see the mental foramen. Okay, both sides, right? I'm going to do this one. I'm going to pick up a cube tool. When I click there, drag it out, I get a three-dimensional image of the mandible in that area. Ah, cool, huh? Now, I can rotate that around 360 degrees just by right-clicking on my mouse. When I get it all out of whack, I can rotate the wheel mouse and get it straightened up. I taught 700 salespeople how to do this from all the different distributors when we first were working with, way back with Plan Mecca, and they didn't have software yet. They didn't have Remexis. Now what? Okay, I'm gonna ask you guys. Oh, that's a cube. I don't want the cube. I'm gonna drag that out again. I want the endo tool. The endodontists get all really freaked out when they see this. Endo tool. Ooh. So I'm going to pick up this endo tool. I'm going to click in here. Now I've got an even higher resolution image. Okay? You're looking at the mental foramen. Well, I like Star Wars, so I'm going to do like Luke Skywalker. We're going in, okay? And I can go in, and I would defy you now, inside this area. First of all, I'm trying to find the canal, which I think is over here. There we go. I would defy you now. I'm going, the inferior alveolar nerve canal's in there, okay? We're going down, that's it, right there. Okay, you tell me how you could find, fat in that area. You're not going to be able to, all right? You can't even find the nerve in the vessel. You'd have to do MR in that area to see it. But can you imagine trying to take software to go in there to see what, how cool that would look, and you're looking and looking, and you're never going to get there. It's not in our paradigm just yet. They are working, by the way, on a cone beam machine specifically for soft tissue. So when they get that done, maybe we got a chance, okay? But I mean, I can make sexy images, guys, okay? And I hope I didn't offend anybody by using the word sexy, all right? Okay. So just a quick demo on the power of the software. It doesn't happen with the machine. It happens with the software. 2 packages, 3 are great. Anatomage in vivo, Cybermed's On Demand 3D, the one I work with. And by the way, nobody has that endoscopy tool except Cybermed. When I see a mass in the airway, I go down the airway and I make an AVI video. And when you bring it up chairside to show Mrs. Jones she's got a lump in her throat, there it is in living color. You can pause it and show her. Go down the airway, right from the oral pharynx all the way down to the pharynx. All right, so, I found this guy late in life. But if he had the best rules. Does anyone know Robert Loeb? If what you're doing is working, keep doing it. If what you're doing is not working, stop doing it, okay? If you don't know what you're doing, do nothing. Now, this is the educational piece. This is why you're here at these meetings. But please, even if you're into a OSA, sleep disordered breathing, get a mastership. Get the fellowship, whatever it takes to get to the level of understanding it, and never make the treatment worse than the disease. That's where this area has gotten in trouble. okay? I got another one. If you think you know what you're doing, think again, okay? I'm still here right now, so, all right. So this was lobe. That's what I want to give you as a take-home message when you start looking with all your tools for these cavitations. And some of you have been in there. I was listening to the dialogue between people asking Dr. Lechner questions, and you've been in there, and you've said, yeah, I found it, there it was. Why couldn't you aspirate it out? Make a small window and aspirate. You know, they do that to lots of different lesions. Why can't you inject steroids in there? I don't know if they'd have the, you know, anti-inflammatory property to get rid of some of those mediators that are, I don't know. There might be other treatments than surgerizing, okay? All right, so this is what has to happen. It's already happened for BRONJ and OJN, but not so much for NICO, although I think the people that I heard this morning are doing a good job keeping that going. The best evidence I could find for osteonecrosis comes out of the spine literature, okay? And one of the things that they did is they took topics and went through a whole, you know, they did the real evidence-based medicine approach. They looked at these three areas for AVN. They identified a bunch of records. They narrowed it down from duplicates. They screened some out and excluded a bunch. They had some left. They did a full review. 81 studies out of 392 were suitable for a review. And they looked at cytotoxicity, genetic factors, and ischemia. I can tell you right now there were no genetic factors that they could identify from that review. There were things, cytotoxic things, and there was definitely ischemia. So now, I don't have time to do, you know, oral osteonecrosis of the jaws, but there is good criteria for defining it. You have to have a bone exposed area for 8 weeks that doesn't respond. So, duh. And they've done a lot of work in, you know, in BRONJ, so I'm not really going to go all that way there. But chemotherapeutics and HIV antiretrovirals were what they identified as potentially problems with the vascular necrosis of vertebral bodies. Now, does anyone know what the slippy molecule is? SLPI? See, you're all bright dentists. You all been doing this for years. Anyone ever wondered why saliva is not a transmissible fluid for HIV? Anybody ever wonder? No. I introduced it when I was on the board for oral medicine. It's secretory leukocyte protease inhibitor. Sound familiar? Protease inhibitor? Guess what? Comes out of the parotid. Large amounts of it. So kissing, spitting, all that stuff. Saliva is great. You gotta have spit, okay? So that now is on their exam. So everybody in oral medicine knows that. And by the way, your best friend in the area that you practice in should be an oral medicine, oral facial pain specialist, unless some of you are also one of those. And the best guy I know is Jeff Okeson. I taught with him at UK. He's now the interim dean. But the best thing he did was find Weldon Bell. If you can find the oral facial pain book by Weldon Bell, now I think it's Bell's Oral Facial Pain, and it's, you know, Eversole, or Okeson rather, as the other author. But he used to go visit Weldon's widow for years after Weldon died, but he has an algorithmic approach to pain that should be in everybody's office. So, all right. So they do all these big studies, the Condor study, this is in the Journal of Dental Research. They look at all the osteocrosis of the jaws. They've done this. They've had enough case studies and enough things come out that they can now actually have evidence for it. So I'm not going to, you know, basically belay that. I want to get into the imaging. However, when we get to a vascular necrosis, could be related to, from their literature review, blood vessel disruption, duh, okay? There's no mention of fat here, but interluminal obliteration, extraluminal obliteration. So I don't know, maybe they're going down the scientific path for that, but maybe the people doing the research aren't coming to the same conclusions of what you heard this morning. So risk factors, this is where I think it comes down to. If you don't know everything that you need to know about every one of those particular disorders, then you're probably not treating your patient properly. You know, you got all this body of knowledge from NICO and from the things that you're studying, but you got to know a whole bunch more about the rest of that patient. You saw today that some of these autoimmune disorders have those high levels of rantase, okay? So, I mean, that was an eye-opener for me. That was terrific. Now, okay, So I get a case, it's from someone, and the clinician may be in the audience. I told them I wouldn't identify them. Notice all my pronouns were thems and never mind. But the patient was a 52-year-old white female. The only history that she gave was that she had trouble sleeping, she was on diflucan, and she was on the birth control pill. And she's 52, so you go, girl, okay? No primary care provider listed, no medical history given. This is a typical history that, you know, you guys get unless you really dig down and ask them some more. Some patients won't provide you all the information. The dentist doesn't need to know that. Well, I go through and I'm doing my exam. Of course, this is not a BRONJ lesion. This is some bubbles inside the right maxillary sinus. Do you know what the ENT people call those? Bubbles, thank you. There's no magic word for it, okay? But it is a sign radiographically of an acute phase of a chronic problem. So she had some ethmoid changes as well in the ethmoid air cells. She had some spinal changes. This is called bridging. It's called a syndesmophyte. So she might have ankylosing spondylitis. But she was in the office basically for her sleep disordered breathing. And when I saw the condyles, I picked up the phone, as I do when I see something unique, interesting, or impressive. I pick up the phone and say, "Does your patient have diabetes? Is your patient on any of these, bisphosphonates? Well, look at these condyles." Okay, I put, oh, that's for ankylosing. You don't have to worry about that. These were her condyles. Look at that right condylar head. It's almost totally dissolved. The left has big subchondral cyst formation. I can't even say anything about the joint space. By the way, the scanner is not a good scanner. So when they phone me to talk to me about it, they'll get my opinion. But you can see that gross destruction, dissolution of bone, even this, I don't think this is just a pneumatization of the articular eminence. I actually think there's changes in that area as well. So look at these images, and these are just thin slice grayscale images. I don't even have to stay in that paradigm. I can go 3D surface rendered color, I can do slab rendering, I can make all kinds of sexy images, okay? You know, but what I did is I said patients should be questioned about the use of bisphosphonates, which could relate to condylar changes. In addition, consideration should be given to referral of the patient to an otolaryngologist for clinical and endoscopic evaluation of the paranasal sinuses, especially if the patient is symptomatic. This is the 3D condyles that I got out of that scan, and it's terrible. There's so much scatter, artifact, and I can't get rid of it. No matter how good my software is, I can't. And trust me, I can make sexy condyles, okay? This is a different patient. This is a nice scan. You can see the surface, topography. You can see the alteration, the difference in size of the two heads. So I can make these images. You can make these images. You just have to learn how in the software, and you have to have good software. So, see, I can make sexy images. Now, we'll go back to the neuralgia-inducing cavitational osteolysis, or it could also be termed, a vascular osteonecrosis. All right. So if you accept that, probably the best way to look at it is with MR. But if you start sending all your patients that you identify a quote suspected area, related to some underlying systemic or pain problem, and you start sending them all for MR, I just don't see that happening, okay? You could, but you can see the different weighted signals. This is a vertebral body with some destruction in the middle of it, bright signal. This is fat suppressed or T2 signal, and you get the fat and the edema coming out in there. So now, there are confounds. Don't worry, I'm getting to some images, I promise. Anatomy, artifacts, imaging modality itself, okay, the type of scanner you buy, known entities. I mean, there is an osteoporotic bone marrow defect that occurs after surgical extraction that is totally asymptomatic, that looks the same forever, that we periodically radiograph to see if it's getting worse or if the patient has symptoms. Of course you might go in, but it's frustrating, trying to find a diagnosis, and your surgeons. If you all saw this, like I did, this is actually conventional CT, non-enhanced. This is the sphenoid bone, okay? This is the pterygoid process region, okay? And if you look in there, I swear to God, the first time I saw that in cone beam, I'm going, what the, you know? Is that a central giant? No, it couldn't be central giants. Maybe it's a giant cell tumor. Maybe it's an aneurysmal bone cyst. It's arrested pneumatization. It happens quite frequently. I see it on cone beam. I see lots of things on cone beam that you have no idea of until I put them in the report, give you a citation, and get it back to you. That's why I can lecture. I'm going to be lecturing till I'm 92, I'm sure. So, but I get images like this, small, you know, CBCT field of view. This is an extraction site. You know, you swear to God that doesn't look any different than what Dr. Lechner showed us, but this patient's totally asymptomatic. Further forward, there hasn't been a root canal done. This is thin slice, so you're not seeing all of the root. There might be something in this canal. But, you know, is this a cavitation? Is this a cavitation? I don't know. We go further forward. You look up here. And then what about this? I saw one in the posterior part of the mandible this morning look just like that. Well, oops, that's just the submandibular salivary gland fossa. So unless you've got all the data, if you've got cone beam and you're not using 3D color surface rendering and you're not learning how to use the tools in your toolbox with your machine, then you're shortchanging your patient. Here's a case. The complaint was that the guy asked, he said, "Hi Dale, thanks for help. Patient is 61. Doctor has concerns about a cavitation on the lower left." I only have a few of you that send me these kind of things. By the way, I don't want any more. I'm not going to find them any better than you. Just learn how to do it, okay? But she has tenderness in the jaw and her cheek is swollen. Well, the first thing I notice is just some anastosis in the jaw. And I'm thinking, well, where the heck was the root canal? So I go in there and I'm looking and I see this big space, I see this space, and I'm going, yeah, but probably the root canal teeth that were treated and then extracted had to be in this region or this region. So I'm going in, there's just the anastosis. You can see the different views you get. She also had, does anyone know what these are? These are loose bodies in the atlantoaxial junction. Guess what? They can refer pain to the face. Oh, damn, another thing to worry about, right? Now, so I go in and I'm going, are they talking about this? Are they talking about this? Did they take the tooth out or do the root canal because some dentist in the past didn't know that was just a normal anomaly, you know? So I go in, I'm looking at that area, and I try and do sexy imaging. This isn't sexy. This is basically, I wasn't convinced there was something going on. There was no root canal done there, and certainly no tooth extraction. Maybe there was a third molar, but it wasn't in the last little while. But I thought maybe this is the area, so that's where I went and looked. And I did some, you know, multiplanar images looking at that area. I still can't tell you whether that's her problem. Then I go in, I change that area. I look at that big one at the back, and these are just going from more posterior to more anterior, and you can see you can get any type of display you want in there. Still thin section. I can't tell if that's it. I tried to compare that side to that side. I'm not impressed that there's anything going on there. And I don't have to pick up a handpiece or a surgical drill and go in there. Where I go is I go to court sometimes after somebody's gone in with a surgical drill. And if you see, you know, these are 3D surface renderings, slab renderings at about 5 millimeter thickness. I can put the soft tissue back in there, but only very marginally. So I can do that, and you can see that this side looks like there's something more going on than this side. By the way, that's the inferior alveolar nerve canal, and this is part of it here. Is that a cavitation? I don't know. I am not going to solve your problems. I wish I could, okay? I can make sexy images, all right? This is a 3D slab rendering. You can see there's calcified, elongated stylohyoid ligaments right down to the hyoid. No symptoms. But if they go, guess what this is? This is the bifurcation of the internal and external carotid, and that's the styloid process. It passes through the bifurcation. If it gets big and they turn their head and they say, I got referred pain to my ear or my occiput or wherever, that could be it. It's a carotid impingement by the styloid process. You can't do this in cone beam. This is medical conventional CT. This is an intubation tube, and this is contrast agent. We don't do that. So here, 2 cases, and then we'll call it a day. Find the defect for me. Shout something out. Where do you want to look? 19. Everybody wants to look at 19. Yeah, okay. We would look at 19. Somebody might look up in here. There has been some root canal procedure, so maybe there's something going on. I looked at this and went, that looks odd. So I did a thinner slice, and you can see it stands out a little bit more. This looks about the same. This looks different, and this is the same area as the other side. There's the mental foramen, of course, and the inferior alveolar nerve is probably this portion, but I can't tell you what's going on in there. And the sad news is, I don't think it was anything. You know, it could have been a traumatic bone cyst. It could have been an osteoporotic bone marrow defect. I don't know why no surgery's been done in there. You know, if there is a history of trauma or something that might lead you to that other diagnosis, it could be. But there's no way I would, as a dentist, go digging in there unless the patient had a complaint. Never make the treatment worse than the disease, okay? I even did it in color. This is more anterior, this is more posterior. This was the area of concern, and I went, well, look at the marrow pattern here. Bone has marrow in it. I think the approach that I saw this morning at looking at the inflammatory mediators and the basically immunologic responses and the cytokines and things is the way to do it. But, you know, do you have to surgerize, or can you get it out some other way? Well, that area, again, that I was looking at when I did the 3D rendering was just a prominent mentum and very deep fossa. This patient had absolutely no complaints. So this is a confound. Unless they've got a complaint, unless you followed or did the treatment and followed the course of the treatment, I would be very hesitant. This is probably the second last case. Look at that maxilla. In thin slice, you're going to drive yourself crazy because everything looks like a cavitation, okay? And you look at this and you go, oh my God, what's going on here? Well, you know, I recommended periapical imaging and vitality testing for tooth number 10, okay, as well as 7 because I saw another area here. But one of them was more prominent than the other. This is 10, this is 7. 10 looked a little bit more when I did the 3D color, but this is what it looks like on the panoramic. You wouldn't even start there. You know, if all you have is a panoramic, great. You can go and take a divining rod and find those cavitations, okay? But you're not going to find them in cone beam any better. You're just going to get confounded, all right? So I took a look at both of them. This is the number 7 region, and it looks pretty normal to me. It looks normal on here. Number 10 didn't look quite as normal. So I think there's a widened canal. I think there's dissolution of bone. I think this is probably normal, and this isn't. And they are so similar in appearance. That's why I suggest that they do vitality testing and take periapicals. Okay. Last one. This is when a tooth has been extracted. Sometimes I get these cases where there's been, you know, impingement on the inferior alveolar nerve canal, or somebody put a bone, burr and traumatized the lingual cortex there and maybe damaged the lingual nerve, and they find a neuroma surgically, and we go to court. But a lot of teeth just heal. Think about the number of extractions that are done in patients. Why isn't there more phantom limb pain? You know, when a diabetic loses a limb, they still feel toes and have painful symptoms. That stable neural pathway going back that says, my foot hurts. You don't have one. You know, it's like, hello, why don't you think that with all the extractions of teeth, we get more of the type of problem I've heard about this morning? Well, I think there must be an underlying immunologic compromise or some other disorder going on that basically makes them more predisposed to the changes for the osteolytic changes that you saw this morning and the chemicals that are released. So I don't know, you've got 50 years of research right there, okay? All of y'all. That's a good Texas expression, all of y'all. So I went in there looking. This was not referred to me, you know, for anything. They basically, you know, it was a cone beam scan they did, a small field of view, and I'm looking at those, and I said, I got to show these folks these images. There's thin slice. There's a little further back. This is what I can do and sometimes you have to be put up with the background because we can't separate. We're still working on the presets to try and separate different density tissues. And I can get sexy images of this. This is the same one. And so what I wrote this up as is a possible focal hematopoietic bone marrow defect, and I put this in. I always put a citation in if I think there could be certain, treatment rendered. And this is to caution them that, before they go in, they ought to watch it radiographically. But if they do go in, if there's some history or symptomology, then they have to submit it for histologic evaluation. So I want to thank you. That's a picture I took. There's a way of doing that on your iPhone, by the way, but it's in your text portion of your phone applications. My son taught it to me. Isn't that cool? That's the Boston skyline from my window in the hotel. Anyway, I want to thank you, and I want to leave you with one quote from a 17th century physician who was also a priest, Per Latham, his name was. The diagnosis of disease is often easy, often difficult, and often impossible. Questions? I'm the only guy that stayed on time today. Oh no, Dr. Lechner stayed on time too. All right. Yes. Can we have the lights up so I can see the, thanks. And a microphone.
We're going to get the microphone right now.
Throw it
come
to
up?
him. I know what you're going to ask me. Yeah, he asked me at the
Is
break.
it on? You had nothing on it.
Check, check, check.
Test.
There you go.
Whoa.
Okay.
Now we got
In
everybody.
the last 4 years, I've taken probably over 2,000 cone beams on children under the age of 8, some as young as 2. So does one of the attendings from Boston University's orthodontics department who will be here after lunch. Could you, about the medical defensibility of this practice in terms of ionizing radiation and age?
Repeat the last part of that question again.
The medical defensibility of
Oh.
subjecting, kids.
What you're really
that-
talking about is dose.
Yes, yes.
Yeah, the New York Times, the maiden
nothing-
of journalism.
Ionizing
Good,
radiation.
good.
if
I
you-
haven't answered his question yet, so if you have nothing to say, just hold on to the mic. All right. The New York Times did an article, and it was a hit piece. It basically looked at only ICAT data, which has the highest KV and MA of any settings, but can be dialed down. And they said, orthodontists are frying kids, and it hit the press, and everybody got, oh my God. And even schools changed some of their practices and went back to cephalometric and panoramic and a hand film to do the assessment, because everybody was worried about dose. Well, the dose now for all machines, you can't, it's like apples and oranges because there's small fields of view, there's large fields of view, there's different MA and KV settings for machines, different voxel sizes. If you pick a smaller voxel size, it'll increase the dose. But the dose is around, and I don't care if you don't remember or know the dose units, 12 to about 100, 120 microsieverts, okay? The dose from a conventional medical CT scan is 2,100 microsieverts. The dose from walking around the planet, from the radon and the rocks and all the devices that we use, is around 3,600 microsieverts. So one CT scan on a kid is equivalent to 2/3 of their annual walking around the planet dose. So our cone beam, okay, if you need the information, if you have examined the patient, determined the needs, said, I'm going to, I'm looking at whatever you're looking at, and cone beam is going to be the best modality to do it, I would say that it's relatively safe, that it is totally defensible. But it has to be, I examine the patient, I determine the need, this is why I'm taking it, okay? Now, the other thing is, if low-dose ionizing radiation that we get from radon, okay, I mean 2/3 of our annual doses from radon, it's in the rocks. There's no rocks in Massachusetts, right, or anywhere where you live. If it was so bad, why aren't we all dead? Why did it take a meteor to kill the dinosaurs? Blanket out all the sun and not grow anything. There's now evidence surface, it's not just now, it's been happening for 30 years, to actually say low dose ionizing radiation is also immunoprotective. What do I mean by that? It means that if you get an insult to you, and Boyd didn't even talk about it, at the same time those insults are happening, you've got repair enzymes kicking in. So if you got a hydroxyl radical created by the ionization of water, first of all, most of them recombine and cause no problem from radiation. But if some stay around, repair enzymes kick in, and they actually get rid of and do things to the body to keep it safe. So through evolution, this low-dose ionizing radiation that's been on the planet with us ever since the planet was formed has been around. If anything, that linear threshold model is just a model. It's now been proven that you can't say anything about that low-dose end of it, that in actual fact it's the way our bodies are challenged to actually change and deal with the problems of low-dose ionizing radiation. So long answer to your question, but it's in my mind, and I'm a little heretic in my organization, okay, because they're all, they worry about every microsievert you're ever going to get. Some of you out there do too. Okay, next question. There was one over here, this young lady. I can say young because I'm old. So. Everyone's young to me now.
I just had a question. Since you're not taking any new CBCTs to read, do you have any reference where to seek a radiologist that would read for these types of things? Until we take the class.
Who can I send them to? Is that what you're telling me?
Yeah.
I think just about anybody in our particular discipline, including me. I still take on patients and clients, don't worry. But, to go looking for them is a task that is time consuming. I mean, those images don't happen automatically. You guys get the benefit. You have a staff member take a cone beam scan and you get $395 for it. I spend anywhere from 20 to 40 minutes putting the data together, doing the imaging and making a report, and I get $75. My deliverable is a lot lower than yours. So it's like, I get clients, well, my report's not back. Well, no kidding, Sherlock. It's only been 7 days, and 2 of those are the weekend, and I need a weekend just like you, and you don't work Friday anyway, so what the hell are you complaining about, So, you can find people. Where do you live? Where's your practice? Where? Washington State? Send it to the school, Curtis Chen, and there's a couple other people up there that, and if they don't, they're probably reading. There's a group called Beam Readers on the West Coast. They're always looking for clientele, but they're all academic radiologists that read it part-time. There's only about 8 of us in the country that do it full-time, okay? But there's about 400 of us total. I mean, we're bigger than pathology even, but anyway. Any other questions? Because I don't want to go on to your lunch break. One here, one there, and then I'll quit.
I want to make a statement.
Statement, okay.
I have a lot of patients that come in, especially with children, and they're freaked out about ionizing radiation. And I can talk to them all day about what the normal radiation does.
You need external validity, and I'm going to tell you where to... No, I'm going to answer your question. You ready?
Ready.
Okay, and I know it's not a question. You're making a statement.
Statement, yes.
Go to the following. Get your pen out, write it down. Go to learndigital.net. Okay, and on that website, I have one statement on the page. It says, patients worried about radiation? Click here, and you click. And it's a one-pager that you can hand to the patient.
I've done that, and they're still after me, so something
Is
that
it
helped
off
me.
my website?
No, from
No,
other someone. Yeah.
listen to what I'm telling you, okay? Quit
Well,
talking over me, all right? On that page, because I need to get to the end of it, no, seriously, you're laughing, but you're not listening. You can't laugh and talk at the same time and not listen, okay? All right. There are equivalent risks that patients take, and it's in a table, and it comes from very good sources. Insurance and morbidity tables, okay? Known causes of death and it's taught to every radiation technician in the country every year. Equivalent risk. You ready for this? Living 2 days in New York. Living 7 days in Denver, okay, because of the mile high up and less. 40 cans of soda. A half a bottle of wine, which is where I'm dying, okay? I should be dead by now. So what the patient has that, the mother has that in their hand. They're smoking on there, okay? Known cause of death. And that's equivalent. It's 1 in a million. And they say, well, that's what's equivalent to a full mouth series of x-rays in film. And that's right at the top of the page. So you go, Mrs. Jones, I do digital imaging. I don't even use film anymore. So my dose is even less than that. And here are the risks that your family and you are taking every day. It's very powerful. I know because I have people download it, keep 30 copies, and hand it out. Okay? So you're welcome. And I'm sorry I was being so rude, but I'm cutting into your lunchtime now. Yes, ma'am. Are we having fun yet?
Hello. So I'm ready to buy a cone beam. Where do I go to learn how to make sexy images that I can read?
Well, first of all, I always say find a colleague who's got a machine. First of all, drill them, you know. Does it work for what you want? How easy was it to learn? Number two, you already have a supply side person, I'm sure, right? Who's your distributor? Patterson. They're going to focus you in one direction only, okay? You may want to look in other directions as well. Not that it's not to diss them. What I'm saying is you start there and you hear the pitch, okay? And then you can compare it to other machines. Top tier machines, in my mind right now, everybody's going to write this down. I'm going to get from the vendors. Plan Mecca, Merida, ICAT, and not in any particular order, okay, and Cavo. And the Cavo might be in, no, it's with Shine. However, Patterson does distribute other. You know what Patterson does? I mean, every distributor does this. What's my margin? I want a digital device. Oh, you got to buy Schick. Why? Because it's the best. Why? Because I get a higher margin than I do on this other. No, that's really when it boils down to. So look at your colleagues, ask them about it. I'd have 2 or 3 of the vendors in to say, show me what you got. I'd go to an actual, you know, commercial dental meeting like if you're ready to buy now, then you're stuck because, well, maybe the Greater New York, because that's all about vendors, and go see it in action. Pick up the mouse. See if you can make it do what it's supposed to do in the software rather than depend on the, oh, look at what we got over here, you know, and they show you their best example. I can show you thousands of images that are crappy. And some of it is lack of attention to detail. Some of it is the machine itself. There are some lower tier machines that people buy for price. And that $395, by the way, if you do the math, I've got these services that I offer. I'm going to need cone beam for these because it's the best modality for the job for that particular task. Do the numbers. Do your ROI. And for you as return on investment, for a radiologist, it's region of interest, okay? So, and it is, seriously, that's a medical radiology term. And then look at it, and you'll be so surprised. I'll give you, and I know I'm talking a long time, a panoramic, a digital pan. You ready for this? 4 pans a day, 4 days a week, 44 weeks a year. Easy numbers for me to remember. At $75 a pan, generates $58,000. It's the highest margin of anything you do in your office. Now, with my radiology hat on, that doesn't mean everybody gets a pan. It doesn't mean everybody gets a cone beam. It means you examine the patient, you determine the need, but I'm telling you, most patients that walk in the door need some type of radiographic examination, and when you do the numbers, if you've got software that does productivity, just have your staff member put in the tools, all the radiology services for a year. Print the report. Don't put anything else for product, just the x-ray services. Print out that printout, and you will then sit down because you're going to go, holy crap, I make a lot of money off these x-rays. And it makes you a better clinician when you use it the way I told you to use it. It's okay. You got to follow up, but that's the last one. Sorry.
Well, so if I buy an Atomage or one of these softwares, who teaches me how to use that? Because I don't want to suck up everybody's time. Okay.
Yeah.
All right.
Sorry about the follow-up question. Now, you can go to drconebeam.com, and I post my meetings. And there are many that I actually do hands-on courses for stuff, okay? But, you know, it is a learning need for everybody. And the vendors don't know how to apply their tools to the diagnostic task. So thank you very much. Enjoy the rest of your meeting.